CMC joint arthritis is a common condition affecting the base of the thumb where the first metacarpal bone meets the trapezium bone, forming the CMC joint. This joint is essential for thumb movement, including pinching and gripping. Arthritis here is often due to wear and tear of the joint cartilage, resulting in pain, swelling, and loss of function. Prevalence. CMC joint arthritis is particularly common in women over the age of 50. Women are more prone due to increased ligament laxity and smaller joint size. People with osteoarthritis in other joints. Manual laborers or individuals with hobbies requiring repetitive thumb use, e.g., knitting, gardening. Etiology. Causes. CMC arthritis is primarily a result of osteoarthritis, but may also be caused by trauma or injury. Fractures, dislocations, or repeated sprains of the thumb can predispose the joint to arthritis. Ligament laxity. Some individuals may have naturally looser ligaments, leading to joint instability and early cartilage wear. Rheumatoid arthritis. While less common, inflammatory arthritis can affect the CMC joint as part of a systemic disease process. Risk factors. Age. The risk increases with age, as joint cartilage naturally wears down over time. Gender. Women are at higher risk, especially postmenopausal women. Repetitive use. Jobs or activities that involve frequent gripping, pinching, or twisting motions, e.g., hairstylists, musicians, increase the risk. Genetics. A family history of arthritis can increase the likelihood of developing CMC joint arthritis. Previous injury. Prior trauma to the thumb or hand may accelerate the onset of arthritis. Clinical presentation. Patients with CMC joint arthritis often experience the following symptoms. Pain. The most common symptom, especially at the base of the thumb. The pain worsens with activities requiring pinching or gripping, e.g., opening jars, writing. Swelling. Swelling may occur at the base of the thumb, making the joint appear enlarged. Weakness. Reduced grip and pinch strength are common, making daily activities difficult. Stiffness. Joint stiffness, especially in the morning or after periods of inactivity, is common. Deformity. In advanced cases, the thumb may develop a Z deformity, where the metacarpal base becomes prominent, a result of joint subluxation, causing the thumb to appear shortened and bent. Diagnosis. Diagnosis is based on a combination of clinical examination and imaging studies. 1. Physical examination. Grind test. The examiner grasps the thumb and applies axial pressure while rotating the CMC joint. A positive test elicits pain and a grating sensation, indicating cartilage damage. Palpation. Tenderness is typically localized over the CMC joint, and crepitus, a grinding sound, may be felt with movement. 2. Imaging. X-rays can reveal joint space narrowing, subchondral sclerosis, and osteophyte bone spur formation at the CMC joint. Ultrasound or MRI. These are not commonly needed, but may be used in more complex cases to assess soft tissue or ligamentous damage. Differential diagnosis. CMC joint arthritis can be confused with other conditions that cause thumb or hand pain, such as de Quervain syndrome. This involves inflammation of the tendons in the thumb and is typically more localized along the radial thumb side of the wrist. Trigger thumb. This is caused by thickening of the flexor tendon sheath, leading to painful locking or clicking with thumb movement. Scaphoid fracture. A break in the scaphoid bone in the wrist can cause pain at the base of the thumb, though this is more traumatic and acute in onset. Treatment. Treatment for CMC joint arthritis focuses on relieving pain, improving function, and slowing disease progression. Options range from conservative to surgical interventions, depending on the severity. 1. Conservative management, activity modification. Reducing activities that aggravate the joint, such as excessive gripping or pinching, can help alleviate symptoms. Splinting. A thumb spica splint or brace can immobilize the joint, reducing pain and inflammation by limiting thumb movement. This is particularly effective in early stages. NSAIDs. Non-steroidal anti-inflammatory drugs, e.g. ibuprofen or naproxen, can reduce pain and swelling. Topical analgesics. Capsaicin or NSAID gels may be applied to the skin over the joint to provide localized pain relief. Steroid injections. Corticosteroid injections into the CMC joint can reduce inflammation and provide temporary relief of pain. These are useful in moderate cases, but are not a long-term solution due to potential side effects with repeated use. Physical therapy. Therapy can focus on strengthening exercises to improve the stability of the joint, range of motion exercises, and joint protection techniques to prevent further wear. 2. Surgical treatment. Surgical options are considered for patients with severe CMC arthritis who fail conservative treatment. Options include trapeziectomy, removal of the trapezium bone, which forms part of the CMC joint. This is a common surgical option and may be combined with a tendon interposition procedure to help stabilize the joint. Ligament reconstruction and tendon interposition, LRTI. After trapeziectomy, a portion of a nearby tendon, usually the flexor carpi radialis, is used to stabilize the thumb by filling the space left by the trapezium. Arthrodesis, joint fusion, involves fusing the bones of the CMC joint to eliminate pain. This procedure reduces motion but preserves strength for gripping. Arthroplasty, a joint replacement surgery where the CMC joint is replaced with an artificial implant. This is less common, but may be considered for specific patients. Prognosis. The prognosis for CMC joint arthritis is generally good, especially with early diagnosis and conservative management. However, as arthritis is a degenerative condition, symptoms may gradually worsen over time if left untreated. Surgical outcomes are typically positive, with most patients regaining function and experiencing significant pain relief. Prevention. While CMC joint arthritis cannot always be prevented, the following strategies can help reduce the risk or slow the progression. Joint protection, using assistive devices, e.g. jar openers, to minimize stress on the thumb joint. Avoid repetitive strain. Modify work or recreational activities that involve repetitive gripping, pinching, or twisting. Maintain hand strength. Strengthening the muscles around the CMC joint help provide better joint stability and reduce strain.